So, Assalamualaikum. My name is Dr. Maluk and I will be present today's course Urology session. So, my presentation topic is Etiology and Epidemiology of the Urolithiasis. And learning objectives are incidence and prevalence of the stones, risk factors, which are further categorized into patient factor and the stone factors, and theories of stone formation. So, what is a stone and when can define? So, stone is defined as these are the polycrystalline aggregate composed of varying amount of the crystalloids and organic matrix. So, incidence and prevalence, the lifetime prevalence of the kidney stone disease is estimated to be 1 to 15%. That's varying according to age, gender, race, and geographic location. Around the world, prevalence rate vary ranging from 7 to 13% in the North America, 5 to 9% in the Europe, and 1 to 5% in the Asia. Data from the National Health and Nutrition Examination Survey suggests that a linear increase in the prevalence of the kidney stone disease for US adults over last several decades, with most recent prevalence estimated to be 8.8 for the period of 2007 to 2010. Incidence of stone disease increased in all age group in men and women, with the peak incidence in the men is 30 to 69 year and in women 20 to 69 year. It has been suggested that rise in the incidence and prevalence of stone disease is seen in the US and worldwide due to detection of asymptomatic calculi through increased use of radiological imaging. The prevalence of kidney stone disease is also kidney stone disease varies across the Asia, with some areas having higher rates than the other. West Asia, Southeast Asia, and South Asia, the prevalence of kidney stone disease is around 5 to 19% in these regions, which are somewhat referred to as a stone belt areas. East Asia and South Asia, stone disease prevalence is 1 to 18% in these regions. The prevalence of stone disease is high in the Pakistan. Is Stone disease in Pakistan is high due to which is estimated to ranging from 16 to 2.8%. So, risk factors are categorized into two major groups: patient factor and the stone factors. Patient factors include the age, gender, race and ethnicity, geography, climate, occupation, obesity, and diabetes, metabolic syndrome, and cardiovascular disease. Uh, According to age, stone disease is uncommon in less than 20% of the age, while the peak incidence is noted in 4 to 6 decades of the life. In women, bimodal distribution of the stone disease is noted, with second peak incidence occurring in the fifth to sixth decade corresponding to onset of menopause. While gender distribution, the stone disease affected adult men more commonly than the adult women. Men affected 2 to 3 times more than the women. However, recent evidence suggests that incidence between the men and women is narrowing. According to race, in the United States, black people have a highest risk of kidney stones, followed by Hispanics, black people, and Asians. However, the risk of kidney stone in the black people has nearly doubled in the 60 to 74 year of the age since 1970. The geographical distribution of the disease tends to follow the environmental risk factors. A high prevalence of stone disease is found in the hot, arid, and dry climates such as the mountain, deserts, and tropical areas. According to climate, the high incidence of stone disease is noted in the summer months through July through September. It is noted that 1 degree rise in the 1 degree Fahrenheit increase the prevalence of stone around 0.15% in the men and 0.0% in the women. Seasonal variation in the stone disease is likely related to temperature by way of fluid losses from perspiration and sunlight induced increase in vitamin D. High incidence of stone disease is noted as these patients are exposed to high temperature because of the low urine volume and the pH, higher urine specific gravity, high uric acid levels leading to high urinary saturation for the uric acid stones. According to occupational risk factors include the heat exposure and dehydration. Patients associated with these occupations are supposed to be high for the stone disease, like laborers, farmer, cooks, engineering personnel, and steel workers. Metabolic evaluation of these groups showed a high incidence of low urine volume, pH, and high uric acid levels and high specific gravity, leading to formation of the uric acid stones in these occupations. Obesity, diabetes, and metabolic syndrome is also associated with the stone formation. Uh, a high BMI can lead to excretion of the urinary oxalate, uric acid, sodium, and phosphorus than those with lower BMI. While obesity and calcium oxalate stone due to increased excretion of the promoter of the stone formation. Obesity and uric acid stone formation is primarily influenced by the urinary pH. So there is some stone factor for for urolithiasis. Uh, Calcium oxalate stones, which account for the 75% of the renal calculi. Causes include excessive dietary calcium, increasing calcium level in the urine promote the stone formation, and high dietary oxalate. Foods rich in oxalate like spinach, nuts, and tea oxalate, as oxalate bind to calcium and form the stones. High animal protein intake increase the uric acid levels and reduce the citrate and stone inhibitor. A low dietary citrate bind with the calcium, reduce the stone formation. Low levels can lead to higher risk for the stone formation. Hyperparathyroidism is also associated with the calcium of stones, as PTH enhances the renal calcium reabsorption and reduces the renal tubular reabsorption of the phosphate. It also stimulates synthesis of the vitamin D3, which lead to enhanced interstitial calcium and phosphate absorption. So calcium oxalate stone risk factor include high oxalate intake, consumption of the oxalate-rich diet complexes with the calcium and from the calcium oxalate stones, as we already discussed in previous slide. High vitamin C intake, excessive vitamin C is metabolized to oxalate, which lead to formation of the oxalate stones. High sodium diet, increased intake of the sodium causes increased calcium excretion, which bind to oxalate and form the calcium oxalate stones. Family history, genetic predisposition to stone formation, as this is strongly associated with the family history. Some GI disorders, condition like Crohn's disease, ulcerative colitis, and gastric bypass lead to oxalate absorption, which lead to stone formation. Struvite or infected stones account for the 15% of the renal calculi. These are the infected stones, causative organisms or the gram-negative rods capable of splitting the urea into ammonium, which combine with the phosphate and magnesium and lead to formation of the stones. These stones are most common in the female. Urinary pH is typically greater than 7 in these stones. So cystine stones, these are the 2% of the overall renal calculi. This is autosomal recessive trait. Cystine lithiasis is secondary to an inborn error of metabolism resulting into abnormal intestinal mucosal absorption and renal tubular absorption of the diphasic amino acid, including cysteine, orthine, lysine, and arginine. These genetic defects associated with the cystinuria and have been mapped to chromosome 2p116 and more recently 19q13.1. So uric acid stones account for 6% of the overall renal calculi. Three main determinants of uric acid stone formation are the low pH, low urine volume, and hyperuricosuria. Low pH less than 5.5, the undissociated form of uric acid predominates, leading to formation of the uric acid or calcium stone. Increased net acid excretion and reduced renal ammonium excretion. Ammonium is a high buffer capacity. Ammonium is a high capacity buffer that works to buffer most of the hydrogen secreted by the kidney and maintain acid-base balance. Low urine volume or conditions that contribute to low urinary volume increase the risk of the uric acid supersaturation. Borghi et al. Noted high uric acid relative supersaturation in the worker exposed to high temperature as compared than with those in the normal temperature. Hyperuricemia is defined as a uric acid excretion of the 600 milligram per day. Hyperuricemia predisposed to uric acid stone formation by causing supersaturation of the urine with respect to sparingly soluble undissociated uric acid. The cause of hyperuricemia include the dietary factors as well as acquired and hereditary disease and defect in the urea transporters. So now pathogenesis of the stone formation. Physical process of the stone formation
Maluk,
comprise of
just a minute. Just a minute. Uh, just to recap what Dr. Maluk has been alluded to earlier and explaining to us is something which is called the etiology of stone formation. Now, since we are in the process of dealing with cancer patients and dealing with stone patients, and often it is said that the etiologies are known for cancer patients, but etiology is known for stone patients. This is not something where the etiology is not known. It might be multifactorial, as we have seen that there are multiple factors. But if you happen to have your experience in a stone clinic, and the purpose of the stone clinic is as such that each and every patient has got a particular peculiar disease and a history that denotes the causation of a stone because of some abnormality. Maybe there is a metabolic defect. Maybe there is something which is related to oxalates. Maybe there is something which is related to metabolism, the congenital anomalies, the gastrointestinal disturbances, the previous history of surgery, for instance, dumping syndrome. So things like that. But there got to be a kind of a system which leads to stone formation. So never think that your presence in the clinic or as a urologist, your presence in the urological field, dealing with a stone patient is something to deal with only troubleshooting. Meaning to say, एक पेशेंट आया, आपने उसको देखा, उसका एक स्टोन था, आपने उसको पीसीएनएल कर दिया, ईएसडब्ल्यूएल कर दिया, ओपन सर्जरी कर दिया. So it's only three ways to deal with a stone. This is not the job of a urologist. If this is a job of a urologist, then this is just 20% or 30% of your job. The next 70% is actually something which needs a lot of thinking and soul searching, which means you got to know the etiology, you got to know the pathogenesis, which we'll see later, and you got to know how you would like to prevent this kind of a stone vis-a-vis recurrence. So recurrence is also very important. So whenever a patient comes to you and there is some kind of a success in the form of stone clearance, आपने कुछ भी किया, ESWL की, आपने PCNL किया, आपने सर्जरी की, बहुत अच्छी ओपन सर्जरी की, उसके बाद उसको कुछ आपने चिट देनी है, चिट लिख के देनी है, काइंड ऑफ सर्टिफिकेट दैट यू आर क्लियर ऑफ स्टोन्स. लेकिन इस चिट के साथ ना कुछ लिख के भी देना होता है. सिर्फ ये नहीं देना होता कि जैसे हम भेज देते हैं ना फॉरन, आप अपस्टेयर्स चले जाएं, एक डाइटिशियन से मिल लें. डाइटिशियन बेचारी क्या करती है, उसके सामने कोई कॉम्पोजिशन भी नहीं होती स्टोन की, केमिकल कॉम्पोजिशन, जिससे कि वो इन्फर करे कि ये बना किस तरह था, कोई मेटाबॉलिक डिफेक्ट थी नहीं थी. वो सिर्फ ये कह देती है कि आप ठीक है अपनी डाइट के अंदर ना प्रोटीन थोड़ी रिस्ट्रिक्ट कर दें, फ्लूइड लेवल बढ़ा दें, डाइटरी फैक्टर्स का ख्याल रखें जो इतने सारे हैं, इतनी लंबे. अगर ये सारे चीज़ें आदमी अपने खाने में बंद कर दे तो फिर खाएगा क्या. दूसरा है कि अगर किसी पेशेंट को वो समझती है कि इसको हाइपर कोलेस्ट्रोलीमिया है, उसको जो है डायबिटीज़ है, मीनिंग टू से मेटाबॉलिक सिंड्रोम है, सो आजकल बड़ा आसान है. You just coin a term which is like a fabulous term, बड़ा सा ग्लैमरस लगता है. आप डंप कर दें सारे पेशेंट्स को into that category. आप कहें कि जी मैं तो कुछ नहीं कर सकता, आपको तो स्टोन होना ही होना था इसलिए कि आपको अगर वजन बढ़ा हुआ था. दिस इज नॉट योर जॉब. यू गॉट टू prescribe something which is like a solution adjustment to a newer lifestyle so that this patient shouldn't come to you in future. So this is my plea to all of you, the young urologists who are in the field, coming into the field. You will be practicing this art and science of urology in future. That please see the end of the tunnel yourself first, and then let your patient see that end, meaning to say the healthy life after you have done your troubleshooting. Murli Sahab.
Yes, sir. When you advise your patient about prevention, then there are the chances of only 14% of recurrence. Otherwise, it's 40 to 50% in 5 to 10 years. So patient must be told about the prevention after the clearance of a stone, and vis-a-vis stone analysis, and if requires, then 24 hours, and then prevention. And prevention, diet, and then medication, both. So it solves the problem of patient and even problem of institute, because we have a workload of stone patients, 60% of workload, and patient used to come again and again.
Yeah.
The clearance is important, and prevention is also important, rather most important, to solve the problem. That is important.
Right, sir. Okay, Dr. Muluk Saab, please continue.
Sir. So, pathogenesis of stone formation. Physical process of stone formation comprises a complex cascade of the event that occurs as the glomerular filtrate traverses through the nephron. So, for pathogenesis, there are the 5 categories. So, urine saturation, supersaturation, nucleation, aggregation, and retention and growth. So, here is a short video.
Formed. How is a stone formed? The first step is nucleation. Ions such as calcium and oxalate that have been filtered into the urine by the kidney spontaneously join together to form a solid crystal nidus. This is called nucleation. There are 2 kinds of nucleation. In homogeneous nucleation, crystals form around a nucleus with the same composition. Crystals of a different composition can also form around the nucleus. Organic materials, such as cell debris, may be deposited between the crystals as a matrix. This is heterogeneous nucleation. The tiny crystal formations travel down the nephron and are usually deposited at the renal papilla, where they undergo the next major phase, growth. Crystals that have already formed then begin to stick together, forming large aggregates. As we can see, crystals can aggregate very quickly. New stones are retained in the kidney, where they can continue to grow for an unspecified length of time until, for reasons that are not well understood, they are displaced and travel through the kidney into the ureter. If a stone continues to grow until it reaches a critical size, which can be as small as 4 to 5 millimeters in diameter, it may be too large to pass easily through the ureter. The edges of the stone may become wedged inside the ureter at the uretero-pelvic junction, where the ureter crosses over the iliac artery, or at the uretero-vesical junction. The result, pain and obstruction, until the stone slowly passes into the bladder and eventually passes out of the body in the urine stream.
So, for saturation, there are some terminologies which should be understood very well. So, first terminology is a concentration product, a solution containing ion or molecular sparingly soluble salt. The concentration product defined as a concentration of the pure chemical component ion or salt, for example, sodium and chloride. A solubility product is defined the point at which the dissolved and crystalline component are in equilibrium for a specific set of conditions. And formation product is defined as a concentration product increases the point at which the solution can no longer be held in a solution and crystal will form. So other terminologies as undersaturated, metastable, and unstable solution. So undersaturated solution is defined as a concentration less than the solubility product. Below the solubility product, crystal will not form and existing stone may dissolve. Metastable state is between the solubility product and the formation product. A period of saturation but no crystallization occur because of presence of inhibitors. Despite concentration of product of the stone forming salt components exceeding solubility product, the crystallization does not necessarily to occur because of these inhibitors. An unstable solution is defined as at concentration above the formation product and the crystals will form at this solution. Supersaturation is defined as a stone forming salt precipitate out of solution and form the nuclei of the crystals. Concentration at this point is also known as a formation product. So urine must be saturated for stone supersaturated to form the stones. So here is a diagrammatic presentation which shows that once the crystals are crystals are in a solution that are below the solubility product defined as a undersaturated solution, crystal will not form and existing stone may dissolve. Once the concentration product increases and the solution between the solubility product and the formation product, this state is known as a metastable state in which the crystal growth will occur. While de novo nucleation is very slow, heterogeneous nucleation may occur, but inhibitor will impede or prevent the crystallization. Once the concentration product increases above the solubility product, the formation product will occur in which nucleation will occur and crystal growth will occur. So nucleation is defined nucleation, there are two types of nucleation: heterogeneous and homogeneous nucleation. Homogeneous nucleation is a nuclear form in a pure solution. As we know that nuclei are the earliest crystals that will not dissolve, and if driving forces, supersaturation level, and an stability of the nuclei is favorable, then nuclei will persist, and promoter will stabilize the nuclei by promoting the surface with binding site that accommodate the crystal structure. Heterogeneous nucleation is defined as the process of formation of crystal in a pre-existing surface. Metastable solution will form the crystal by heterogeneous nucleation. Since the normal urine sample is metastable solution, it is easier for heterogeneous nucleation to occur. Sir, here are some theories of stone formation: nucleation theory, free particle theory, fixed particle theory, nanoparticle theory, and Carr's hypothesis. Nucleation theory is defined as once urinary stones originate from the crystals or other nada emerge in supersaturation solution. As we see the previous slides that for stone to form, urine must be supersaturated, and these small nuclei, uh, if these are small and the threshold is too low, that will pass away. But if this urine is supersaturated, these nuclei will stick into the binding sites and will cause the crystal growth and aggregation and leading to formation of the stone. So free particle theory is defined. Recent studies show that free crystal particle can be formed that are large enough to be retained during the normal transit time through the kidney. Within the time frame of transit of the urine through the nephron, estimated to 7 to 5 minutes, crystal will not grow to reach a size sufficient to occlude the lumen. However, if enough nuclei form and grow, aggregation of the crystal will form larger particle within the minutes that can occlude the tubular lumen. So fixed particle theory or random block theory is defined as anchoring site to which the crystal bind, thereby prolonging the time the crystals are exposed to supersaturated urine, facilitating the growth and aggregation. Here is a diagrammatic presentation which shows free particle theory and a fixed particle theory. Once the urine becomes supersaturated, these crystals will float through the tubules, and these crystals will grow and aggregate. In free particle theory, these crystals particle will large enough to block the lumen and will cause aggregation and further leading to stone formation. When the fixed particle theory has shown that fixed particles, so these crystals will bind toward the particle adhered to the damaged epithelium and crystal aggregate on it, will lead to formation of the stone disease. Fixed particle theory. So Randall in 1973 first supposed renal papilla as an anchoring site for the stone formation. He implicated that the basement membrane as a site of origin of the plaque and subsequent erosion into the papillary lumen surface provide a nidus for the stone formation. Even et al. Redefined this theory as a plaque extends through the medullary interstitium into the subepithelial location. Once the plaque erodes through the urothelium, it is thought to constitute a stable anchored surface to which the calcium oxalate crystals can nucleate and grows in attached stone. So the basic event is that is a vascular injury to vasa recta near the renal papilla. So a repair of the damaged vessel wall lead to atherosclerotic like reaction, which cause the calcification of the endothelial wall, which lead to erosion of the papillary epithelium, and will serve as the nidus for the stone formation. So calcifying nanoparticle, these are the self-propagating particles that precipitate calcium epithet on their exterior membrane, and these have been detected in the blood product, renal stones, as well as in the pathological calcification. These promote the rapid precipitation of the calcium phosphate from the blood under physiological unfavorable conditions. So Carr's hypothesis hypothesized that calculi form in obstructed lymphatics and then rupture into the adjacent fornices of the calyces. Arguing against Carr's theory is the grossly visible early stone element in the area remote from the fornices. So thank you so much.